we had looked at parenteral nutrition. The earlier engagement, the first engagement we had looked at nutrition care process and a brief introduction to clinical nutrition. Looking at the nutrition care process, we realized the four steps: the nutrition assessment, the nutrition diagnosis, the nutrition intervention. Then finally, we looked at nutrition monitoring and evaluation. In there, we looked at different things to do with the types of assessment. Be engaging on further as we continue with you. But then, really, we had appreciated things to do with the nutrition interventions. And this module is a little coupled with diet therapy, so you will be hearing things from here and there. Likewise, we started with something to do in enteral nutrition. First, we looked at the nasogastric tube, then we looked at the nasojejunum, then we looked at the ostomies, the jejunostomy, the esophagostomy, the gastrostomy, and the like. We had looked a little briefly about the parenteral nutrition, whereby we had looked at this as when things fail in the enteral nutrition, but we had also looked at the oral nutrition supplements. Looking at this, we reminded ourselves of the folic acid needed during pregnancy and things alike. So friends, today we are going to go further still in the same line and look at parenteral nutrition. And from today's learning objectives, we expect you by the end of the day or by the end of the engagement to be able to explain the indications and contraindications for parenteral nutrition. This builds on from what we have looked at earlier in enteral. So don't get very confused. It will be a little more, little twitches here and there, but we will be able to get it. I also would like you to describe the components of and types of parenteral nutrition solutions, and also calculate the energy, protein, fluid, and electrolyte requirements for a patient receiving parenteral nutrition. This may be, but we'll also be looking at it. Sometimes it's a little challenging, but nowadays, with a lot of softwares, everything can be calculated. Identify the potential complications and adverse effects of the parenteral nutrition. We know people who are practicing medicine, and everyone in the health sector knows the word adverse effects. Adverse effects and side effects could be mistaken for each other, but an adverse effect might even not be a side effect. We have some good adverse effects, okay, and some bad adverse effects. Okay. We understand that an adverse effect is that effect that is not what the drug is entirely supposed to do, but then at the end of the day, it's an effect it gives off with also the importance that you had prescribed it for. We will also be able to monitor and evaluate the clinical outcomes of patients receiving the parenteral nutrition. Alright, so kicking this off, we understand that parenteral nutrition is a method of providing essential nutrients directly into the bloodstream through a vein, bypassing the digestive system, like I told you earlier on in our engagement to do with the enteral nutrition. The enteral nutrition. Here we had looked at things to do with let's say, for example, the nasogastric tube, where we're saying here we are putting those fluids or those feeds into the stomach. But now we realize that we are having challenges with absorption. Okay, we are having challenges with absorption, we are having challenges maybe with the stomach, and we need urgent support right now. What can we do? So now let's put the things directly into the bloodstream that now the body won't suffer with absorbing. Earlier on, we were trying at least to skip some stages of the digestive system, knowing that, okay, these don't work. Let's keep the digestive system functional. But now we realize that the digestive system is a little constrained, or it's not going to be able to provide us with the urgent need or the urgent support to absorb the nutrients that we want to put into the bloodstream. So we deliver these nutrients into the bloodstream. We're also saying it's a life-saving intervention for people who need to meet their nutritional needs for people unable to meet their nutritional needs orally or through enteral feeding. And we are saying feeding through a tube directly into the stomach or the small intestine, like I had explained earlier. So, what are the indicators for parenteral nutrition? Okay, so here we have malnutrition or inadequate or unsafe oral and enteral intake. If we can't give you something orally or we can't administer anything to you using enteral nutrition, then we will prescribe parenteral nutrition, whereby now nutrients will be fed directly into your veins. And also, we are looking at GI functionality being insufficient. Okay, uh, uh, gastrointestinal functionality, intestinal functionality being insufficient to support the adequate degree of digestion and absorption of the nutrients, like I had explained to you earlier. And also, we are looking at the prolonged GI system failure. Okay, this is more than 5 days, or intestinal failure that is predicted to last more than 5 days. Here, we will prescribe uh, the parenteral nutrition. You realize that now we understand that for 5 days, if you're not getting any nutrients into is someone trying to say something? Could you please unmute? Okay. So, if the gastrointestinal system has failed, or the gut has failed you, then we predict that it will fail for more than 5 days. Then we'll look at parenteral nutrition. Then we're also looking at intolerance of the enteral feeding, or when enteral feeding is unsafe and impractical. All right. So, what are the contraindications for parenteral nutrition? Okay, when someone has a functional and unabsorbing gastrointestinal tract, we do not prescribe parenteral nutrition for people whose digestive system is still at par, where the digestive system is still working, where the small intestines are able to absorb the nutrients, etc. When the treatment is also short, for a period less than 5 days, here we believe we can still be giving you feeds using the enteral nutrition, or you giving you the feeds orally. Okay. And also poor prognosis or patients or family wishes against aggressive nutrition. Or some people, like I told you, might be a little more worried when it comes to an esophageal tube, but people are not very worried when it comes to being put on intravenous fluids. Okay, so what do we do here in this case? What happens is you tend to at least try to explain, but if everything has failed, what do you do? At the end of the day, you will have to go with what the person looks at as the safest option to them, because all these are ways in which you can go well with the type of treatment or type of delivery you're trying to give to the individual. Okay. So what are the routes for parenteral nutrition administration? Earlier on in our second engagement, we had looked at the peripheral parenteral nutrition, which would abbreviate as PPN. Then we had also looked at in this we are talking of the catheter being placed at the peripheral vein. Okay, this is suitable for short-term use. Peripherals, when we talk of peripherals, I hope we understand what peripherals are. Peripherals are the limbs, the limbs, surely, the legs, the arms. Okay, those are the peripheral areas. I beg to be corrected if it's not the correct
I'm good, and you?
definition.
Are
Yes,
you
please.
okay?
Hello? Is someone trying to say something?
No.
Oh, yeah. Then please unmute. So, sorry, then please mute. Uh, Like I said earlier on, that these are just the body parts that we refer to as the extremities, the arms, the legs, and these are away from the central core, okay, the head and the torso. I hope we all know the torso when we talk of the torso. So we are saying that this is suitable for short-term use for periods less than 14 days. So we can put the IV fluid on your leg or on your hand for less than 14 days if we are giving you nutrients directly into your bloodstream. And we are saying that this only partially meets the nutritional needs. Is also a reason as to why we'll be giving you peripheral parenteral nutrition. Then we are looking at the central parenteral nutrition, or some people have called it the total parenteral nutrition. Here we are looking at a catheter being placed on the central vein uh, with high blood flow. Okay, we are trying as much as possible to rejuvenate you. Here with the peripheral is fine. Some people can argue that okay, now the blood flow in those areas is a little less compared to when people are putting you the central. They are putting the IV fluids or the feeds in the central in the central vein, which has a little bit of high blood flow. Okay, so here we are looking at the types. If you can zoom in and look at the type of access, the non-tunneled CVC, the tunneled CVC, the periphery inserted central catheter PICC or TTC, and that would interest you to read a little bit further. At the end of the day, the definitions also you would read, and also you could also interest yourselves with the length of stay. Okay, so who are the candidates for the parenteral nutrition? For the peripheral parenteral nutrition, like we had said, these are short term, okay? And we will look at them as being supplementary when you're giving something entirely where you're using the enteral nutrition, but you can still couple it with peripheral parenteral nutrition. Okay, if things are not sufficient, what we are trying to do in most cases under nutrition is we customize support, like I told you, that if something is still working, that's why we are saying even if someone is on enteral nutrition, you don't let these people have only the tube within them. At least try as much as possible to rejuvenate the oral route in which you're going to be passing in the food, or in which the food is supposed to be passing normally. For the peripheral parenteral nutrition, we are saying this could be supplementary, okay? Supplementary to the enteral, or it could be the transitional phase. You're coming from the total parenteral, now you're in the peripheral parenteral, then you go to enteral, then from enteral, you go to the oral route or oral nutrition supplements, then finally you go to your well-being or optimum health. Then let's interest ourselves with the total parenteral nutrition. Here we are looking at long-term support. Okay, maybe people who we think are going to be comatose. Okay, yeah, people who are going to be in a coma for a longer period of time. We could look at total parenteral nutrition. Okay, their body still needs the nutrients even if the person is in coma, and also for it is suitable for critically ill patients that we know they are in life-threatening conditions. Still prescribe this. So monitoring critically patients on parenteral nutrition. Here we what are the indicators for us to monitor? Okay, what are the indicators for us to monitor when someone is on parenteral nutrition, whether peripheral parenteral nutrition or whether it is total parenteral nutrition? First, we'll look at daily temperature and fluid balance. Fluid balance, we'll look at this that when there is accumulation of fluids, I think what happens is ascites. When there is a lot of accumulation of fluids in the thoracic region, I think, I hope so, if I'm not wrong. Okay. Yeah. Is it in the thoracic region or is it in the abdominal area? Yeah, but this in most cases will lead to heart failures and liver diseases All these are caused by those imbalances. Okay, so uh, there should be ways, or there should be measures in place to help you drain this excess fluid. Okay, yeah. Then every 6 to 8 hours, we monitor, we test the blood and the urine glucose. We don't want a lot of glucose to be in blood and you end up becoming diabetic. And also, with the glucose, we'll be looking at the refeeding syndrome, whereby now you're pumping the body with a lot of nutrients at the end of the day. By the time we start seeing an excretion of a nutrient, then we suspect that either one, the nutrient is not being absorbed well, or two, then there is we are giving you an overload or an excess of that particular nutrient. Okay, then daily we'll check for the electrolytes, we check for the urea, we check for creatine. Then twice weekly we check for calcium and phosphorus. We do the liver function tests. We do the albumin or slash the total protein. Then for weekly we check the cholesterol levels, the nitrogen balance, then the magnesium. But we also check your weight. So calculating the nutrition needs during parenteral nutrition. For energy, we estimate the basal metabolic rate, okay, using the equations based on age, sex, and weight. And for basal metabolic rate, we will engage on it further. But then for the proteins, we are looking at 1 gram of protein per kilogram for most patients, okay, per kilogram. When we see per kilogram, we're looking at per kilogram body weight. I hope we are not confused with that one there. Okay. For the fluids, we are looking at 30 to 35 mils per kilogram body weight, and also we account for those additional losses. Okay, additional losses. Where would the losses come from? Through vomiting, through urine, etc. Then for micronutrients, we will include the vitamins, the minerals, and also with these we adjust basing on the patient's condition. All right. So here is a calculation which looks a little bit not new. I hope we've seen it before. For those who have not seen it, we will need to have some engagements at later on. I believe we will do it again. So here we will be calculating osmolarity. Okay, and what is osmolarity? Really, in calculating osmolarity, this is a concentration of a solute. Then you multiply by the number of particles. Okay, for example, we have 1 gram amino acids per liter. We will have 10 moles. Then for the dextrose, 1 gram per liter, 5 moles, etc. But we will look at that later on in detail. It's something we would want to interest ourselves with and do the calculations later on. So what are the recommended daily micronutrients? Okay, daily amounts of the micronutrients that we require daily. For calcium, we require 10 to 15 milliequivalents. Then for magnesium, 8 to 20 milliequivalents. Phosphorus, 20 to 40 millimoles. Then sodium, 1 to 2 milliequivalents. But now that is where the issue always comes from. It is in the balancing these electrolytes, the sodium and potassium and phosphorus. Okay. Yeah, so a lot of care, like I told you, when you're doing nutrition, this is all supposed to be customized when you're doing clinical nutrition, and know what is happening. Are you affecting the sodium potassium pump and etc. I hope that is not a new term. And as for acetate as needed for the acid-base balance, realize that a lot of balance is required when people are at their critical points. And for vitamins, specify daily intake for each: the thiamine, the riboflavin, niacin, the folic acid, the pantothenic acid, B6, B12, biotin, vitamin C, A, D, and E. For trace elements, we specify intake of chromium, copper, manganese, and zinc. However, like I told you, not working in isolation. What I know is you will only be consulted when it comes to these nutrition sensitive parts, but otherwise, you will also have to go and read. And a lot of information, the information is always changing. Okay, yeah, the information is always changing, and a lot of guidelines are coming up here and there. So we need to keep ourselves at par and keep ourselves interested with this. Okay, what is a refeeding syndrome? Like I told you, this is a fatal complication in severely malnourished patients, and we had said this occurs due to aggressive initiation of feeding after prolonged starvation. And this is a very common question that is asked on different interviews. If you claim to be a nutritionist, they will ask you something to do with a refeeding syndrome. If they are telling you reasons as to why you should not be giving uh, 2 hourly feeds for a client who has just arrived, if at all the child is malnourished. This could be something that you could argue out of the refeeding syndrome. And we have said that this can lead to severe cardiac, respiratory, or hepatic and hematological and neuromuscular complications. So we don't want you to lose people because you don't know how to uh, uh, do the calculations of the feeds, okay, the feeds that some children require. For example, if it's 100 meals and you're giving 200 meals, refeeding syndrome is bound to occur. So refeeding should be initiated gradually to avoid metabolic and pathophysiological alterations. That is why we give very little amounts, the 2 hourlies. Then from the little amounts to hourly, we go to a little increased amounts for hourly or 3 hourly, depending on how you want to customize your feeding schedule. Then you go to 6 hourly, like that, until you start changing and shifting from the different feeds along the line. And also we monitor for the electrolytes, especially the phosphorus, thiamine, and other key parameters. We are saying this is a multidisciplinary approach involving healthcare professionals. For example, remember midwife, or not a midwife, sorry, a clinician or a clinical officer might have prescribed a drug that is going to be fed into a child intravenously, and they are also going to be putting this child on a drip. Okay, or they are going to be putting a drip on the child. So what happens is you're also going to come and claim to be a nutritionist and not looking at the time of the feeding or the time when the drugs are going to be administered, and you also just start feeding. You realize that you will shock the system with a load, and then feeding syndrome is bound to occur. That's why I say we can't work in isolation when we are dealing with people's lives. So what are the complications of parenteral nutrition? One is parenteral nutrition should only be applied by the experienced staff. If you're not experienced, you should not do this parenteral nutrition. Okay, you should not feed anyone. Don't go putting cannulas on every place or on every vein that you see. Okay, you're going to cause problems for yourself. Okay, for the individual. For you causing no problems for yourself, it's okay. You can choose to be very careless with your life, but then don't be careless with the life of another person. So trauma such as the carotid puncture and the pneumothorax, then we have the thrombophlebitis, okay, then we have the catheter occlusion, okay, then we have the air embolism, infection and sepsis at the catheter side, and we are saying importance of proper training, aseptic techniques, and dedicated catheters. Okay, yeah. As you can see, a lot of care is required when we are doing parenteral nutrition. So we need as much as possible to take into consideration most of those. Improving calcium and phosphorus solubility in the parenteral nutrition using balanced parenteral nutrition formulas, like I told you. These are easily accessible. All these guidelines are easily accessible. what I wouldn't encourage people is to go reading random articles on Google Scholar. Okay, for your research, hopefully this year or next year, you will be tasked to do to write up theses, or you will be tasked to write dissertations, and you will be looking for information on Google Scholar. You'll be looking for information on ResearchGate, information to cite. But when it comes to treatment, really, when you get a guideline, that is the first thing. But then the next thing is asking the experienced people on the ward. Okay, you ask the nurses. They are those people who, even by looking at a child, they can know the child is malnourished, the child requires this, the child requires this. People have been in the practice for so long. However much we are saying most of these things have changed, all the guidelines have changed. We don't want to lose that experience that the people already have, that the people who are on ground already have. Okay. We are looking at also the metabolic and fluid-related complications. We are looking at the biochemical alterations due to large osmolar load and also leading to the refeeding syndrome, like I told you. For hyperglycemia is the condition when there is a lot of glucose in blood. So what do? We manage with the insulin. For the fluid imbalances, we try to balance the sodium and potassium. Then for the hepatic disturbances, when we talk of hepatic, we are talking of challenges to do with the liver. So here mainly associated with sepsis or other drugs. Remember I told you when someone is malnourished, in most cases, there will be also those other infections. In most cases, people call them the opportunistic infections. And we are saying here we can only mitigate through carefully monitoring and management of the parenteral nutrition solutions. Okay, so what is hyperalimentation? Here we are looking at the deliberate overfeeding or the reverse catabolism and maintaining the nutritional status. So what are the risks? The risks, we have uremia, we have hyperglycemia, hyperlipidemia, hepatic steatosis, hypercapnia, and fluid overload. And how do we prevent this? By avoiding the exceeding of the patient's nutritional needs. Okay, we measure the basal metabolic rate and using the indirect calorimetry. And some organizations recommend deliberate underfeeding to mitigate risks. Okay, it is better to underfeed someone than causing a shock to the system, because with underfeeding we can always catch up. Okay, we can always catch up. But then for overfeeding, now imagine someone has gone into septic shock. We can no longer reverse this. Okay, yeah. So that is the issue. You rather underfeed because you can always find a way of increasing the feed on the next scheduled time. But then it is very absurd if you are going to lose a case because you overfed an individual. Okay. Yeah. Going forward, how do we optimize parenteral nutrition? With hyperglycemia in critically ill patients, this is very common. Okay. So, what are the causes? The causes is hyperalimentation and insulin resistance to stress response. Hyperalimentation could also be referred to as the total parenteral. Yeah, we remember what total parenteral was. Okay, total parenteral was when we are giving the feeds directly to the individual intravenously using the central parts. So don't be confused when we talk of the hyperalimentation. But we have said that the hyperglycemia or the increase in the blood glucose levels could happen due to this, and also the insulin resistance linked to the stress response. Other risk factors could be the diabetes and also the impaired glucose tolerance, and the complication of the hyperosmolar dehydration leading to potential fatality or potential death if untreated. So how do we prevent hyperglycemia? Okay, we had talked of being deliberate on restricting the glucose, okay, the glucose intake into the body, and also we are saying this significantly impacts the mortality of critically ill patients. So the initial aim is less than 8.3 millimoles per liter, or 150 milligrams per deciliter in the first 3 days of the nutrition support. That is the amount of glucose we are supposed to give. These won't, most of these won't come into your assessments, but they are really essential to know. Subsequent aim, if critically ill, we are looking at 4.4 to 6.1 millimoles, or that's 80 to 110 milligrams per deciliter. Okay, so what are the additions to the parenteral nutrition solutions? We've looked at the micronutrients, we've looked at the vitamins, and we are also looking at the medications such as insulin to prevent the hyperglycemia, the antacids for gastroduodenal stress, ulceration, and also with other medications that will be prescribed by the medical worker. But we need to take into consideration that all these, we sit down with the medical practitioners and ask them what they're prescribing so that we can care for those drug nutrient interactions, and also to know the amounts that are going to be given so as for us not to overshock or overload the system. The role of parenteral nutrition pre and post-operatively, or post-operatively, we are saying the role of parenteral nutrition here, pre-operative is pre-surgically or before you go into an operation. This may improve the surgical outcomes for severely malnourished patients. So here we give the feed before the person goes into an operating room, or before. This is sometimes a step in preparing a person to go into the theater. They could even prepare someone for close to 3 or 4 days before they do those major operations that would grant a person to be on to be bedridden for some time, okay, or do those operations that could cause uh, issues with the digestive system, whereby the individual is going to take some good period of time without eating. So what we do is give you parenteral nutrition. Then post-operative, it is initiated where in malnourished patients when enteral nutrition isn't feasible for the first 5 to 7 days. Okay, and consideration in well-nourished patients if oral and enteral nutrition is not possible for the extended period, like we had said. Okay, and also for severe pancreatitis, we also indicate this, and we are saying it interferes with the nutrient digestion associated with the increased nutrition requirements. So in severe pancreatitis, if the nutrients can't be digested well or can't be absorbed, then we are left only with one option, is to direct the nutrients into your bloodstream. Pancreatitis alone is not an indication for the total parenteral nutrition, where we are looking. However, we look at meta-analysis findings, and total parenteral nutrition increases risk of ineffective complication, surgical intervention, and hospital stay. Okay, yeah. Mild acute pancreatitis, here we will look at enteral feeding to be safe and effective in that area. For total parenteral nutrition in acute pancreatitis, here this is reserved for severe cases where people are unable to tolerate the enteral nutrition, and we are looking at the exacerbation with the enteral feeding and pre-pancreatic surgery with severe malnutrition signs. At the end of the day, we are trying as much as possible to bring a person back to proper health. So what are the 3-in-1 parenteral nutrition formulas? These are ready-to-use bags of the parenteral nutrition containing protein, glucose, and the lipid. Those are the three major nutrients, like we all know. Glucose representing the carbohydrate in this statement. So the components in separate sterile chambers, perforated and mixed before hanging. And what are the benefits? This is easy, it is easy to use for the nursing staff, and it is also cost effective. However, it limits flexibility of the individual patient needs. Earlier on, we required the nurses to be able to mix these feeds on their own, calculating the amount of protein required, the amount of glucose required, or the amount of the lipid required, or the the saturated fatty acids. Uh, However, but now remember, all patients come with their different complications, and they require to be handled differently. So we are looking at the challenge being that there is lack in flexibility, there is lack in knowing when to, if a person comes with that a unique requirement, how are you going to handle that? So in the transitional nutrition, we are saying moving from one type of feeding to another using feeding methods simultaneously from parenteral to enteral nutrition. This means we are going from a severe illness to a little mild, then to optimum health. So gradual introduction of enteral nutrition at a low rate, 30 to 40 meals per hour to establish the gastrointestinal tolerance. Like I told you, we don't expect someone, uh, however much it is easier for the nursing staff, okay, to be on total parenteral nutrition entirely, okay, because they can always locate the jugular, they will put the pill. But we want to rejuvenate the other parts of the body. We want to rejuvenate the other parts of the digestive system. So what we do is introduce enteral nutrition at a low rate of 30 to 40 mils per hour, and also enteral nutrition gradually being decreased as enteral nutrition increases. And if we reach the optimum, we discontinued at 70% of the nutritional needs. If 75% of the nutritional needs are covered by enteral nutrition, we will have to stop parenteral intake. So from parenteral to oral nutrition, here we monitor oral intake and we discontinue parenteral nutrition when 75% of the needs are covered by the oral intake. If someone can eat every, okay, if you can convince a person to eat 75 or drink 75% of that porridge or that feed that you've made, then why are you still putting a catheter on that person? Okay, now you're still feeding them intravenously. Then here we can ably discontinue this. Also, indication for enteral to oral feeding and enterally fed patients are able and willing to eat. The only issue comes with willingness. That is why if a child is unable to eat, but even if a child is malnourished, but they still show appetite, we don't enroll these people on ICP. Okay? We enroll these people as OTC clients whenever they come, and we give them a two-weekly ration. I think so. It's either the RITF or the RUSF. Okay, so indications for the home parenteral nutrition. Here we are looking at provision of this support through a tunneled catheter. Okay, so in cases of chronic intestinal failure, where the oral and enteral feeding are ineffective and unsafe, we look at parenteral nutrition. So you consider for the home parenteral nutrition, if the intestinal failure is irreversible, where people are having cancer of the intestine, and also most common indication when we have short bowel syndrome. Here we are looking at cyclical provision, which is given overnight for morbidity and potential reduction of hepatic complications. Overnight, we don't expect a lot of movement to be happening. Okay. Yeah, that's when we prescribe that. And we are saying this is a coordinated multidisciplinary. We're looking at the surgeons, the specialists, nutrition nurses, dietitians, the pharmacists, and general physicians, district and home care company nurses. Okay, and we also emphasize the importance of a supportive team for success and of the home parenteral nutrition administration. And here we are looking at a tailored care plan for each patient with their unique needs. This is what I told us earlier, that we have to look at the needs of that particular client or that particular individual. What are they suffering from? What disease, what condition are you trying to counteract? That is how best we can give this support to an individual. Also, regular monitoring and adjustment to optimize nutrition support. Friends, that is what I had for us today. I'm a little bit sorry for rushing through through almost each and everything, but I'm having another engagement immediately after this. But I believe when we go home, we can at least appreciate that we have understood things to do with oral nutrition supplements, the nutritional feeding, the peripheral parenteral nutrition, and also the total parenteral nutrition, and a lot is left to be covered by us. Unless we have any questions or any things here and there, I beg to end this engagement here. Thank you for attending. Do we have anything?
On my side, there's no question. The lecture is very clear.
All right. Yes, Yudes. Is there anything?
No, sir. Everything is
All
clear.
right. Then Tito. All right. I think Tito is failing to unmute. Friends, I wish you a good night. We meet tomorrow.
All right. Thank you. Good night too.
Thank you.